Hi, everyone, and a very warm welcome to today's eMHIC webinar. I'm hoping you can all hear me and see me. My name is Fiona Costello. I am dialing in from the UK where it's around 4 o'clock, but I know that some of you will be very early morning or evening. So thank you to you all for attending. It's great to have you with us for part 2 of our Fireside Chat series, Generative AI in Mental Health, Expanding Access, Empowering Lives, and Navigating Ethical Frontiers. In today's session, we're taking on the tough questions about the ethics of using AI in mental health, from privacy and bias to transparency, fairness, and inclusion. Our expert panel is perfectly positioned to lead this important conversation, offering insights from a clinically grounded AI chatbot, Wiser, and an ethical research perspective from Stanford Center for Biomedical Ethics. You'll hear from our wonderful speakers very soon, but first, and as usual, I just have a very few quick things to mention. First of all, feel free to share your current location or area of interest. To do so, you can click on the 3 dots next to your name tag, choose edit, and add your country or area. This allows you to connect with others who share similar interests. If you have any questions for the panelists during the webinar, please feel free to post them in the Q&A box. During the Q&A session, I will do my very best to include as many of them as possible in our discussion. And lastly, today's webinar is being recorded, and as always, the eMHIC team will soon share the recording in the Knowledge Bank. Now, it gives me great pleasure to introduce the first presenter, Smriti Joshi. Smriti Joshi is a clinical psychologist with over 22 years of experience, including a decade dedicated to digital mental health and remote care. She brings both practitioner and lived client perspectives to her work, advocating strongly for ethical, inclusive, and clinically safe innovations in mental health care. Smriti has been instrumental in shaping India's telemental health landscape. She contributed to the telecounseling guidelines developed by the Indian Association of Clinical Psychologists and trained hundreds of psychologists across the country to transition to teletherapy during the pandemic. Recognized nationally and internationally as a thought leader in telemental health, Smriti has authored several articles, research papers, and book chapters, and is often invited to speak on the future of mental health in digital ecosystems. Currently, Smriti serves as Chief of Clinical Services and Ops and board member at Wiser, a global mental health platform that combines AI-powered emotional support with human-led care. We can't wait to hear from you, Smriti. Over to you.
Thank you, Fiona, for that lovely introduction. Am I audible?
Yes, yeah.
Okay, I am going to begin with a short deck that I have prepared for today. So basically, I would just want to take you through my journey as well as Visa's journey and how we have done design our product and services in an ethical way, following all the regulations and all the best practices, the guidelines that existed. We all know that there has been a boom, like an exuberance, when it comes to AI and AI for health and AI for mental health, and things are evolving very quickly. But being in the space since almost it's 10 years now. 2015 is when Visa came in, when Gen AI was not around, and we began with being a rule-based algorithmic um, product. And what you see on the screen is some accolades that we have gathered, as well as some regulations that we have really followed throughout our journey right from the start till now. When we launched, we ensured that we had a escalation pathway because we knew people would be talking and people would be engaging with the chatbot. And so far, we have 11 million lives covered in 95 plus countries. We have 750 million conversations so far. We have worked with a large variety of organizations and platforms. We have 60 plus enterprise partners. We have worked with employers, and we have worked with public health settings like the eMHIC Singapore and NHS UK and multiple US states. We have ensured that everything that we claim or that we said Visa could help with was also documented, and there was research done around it. We have most evidence of any mental health app, about 40 plus peer-reviewed papers. We've done RCTs with Harvard, Columbia, and other leading researchers. And our users who are also co-designers and who have helped us co-design our product, not just by giving feedback, but they're also on the user panels that we have given us 90 plus percentage for helpfulness. And we've also got recognition from Orca as the best app for healthcare very early in 2020. We've got the FDA breakthrough designation. We've got the best of privacy by Mozilla Foundation, and we have the NHS AI award for digital mental health. And I'm not just simply bragging or definitely feeling proud, but not bragging when I'm sharing these with you, because it just shows throughout our journey we've been very conscious of how we have been trying to uh, stick to the promise, but also understand what the perils are and understand what the best practices and guidelines and regulations and different geographies warrant from us when we are uh, bringing an AI product in the market, which we know will be used by individuals across their development span, young people, the people with probably some mental health concerns, individuals who are probably looking for well-being uh, uh, support, people are looking for mental health support. And these are just some quickly documented points on the promise and the perils. We know why the AI is here. It expands access for millions who cannot reach a clinician. It enables early screening, offers a safe space, quick access to some support that reduces stigma and encourages engagement, can complement, definitely not replace professional care when designed safely. And the perils, of course, are, and we are hearing a lot of it in the news these days about the unregulated use of large LLMs, OpenAI, ChatGPT, and the likes. And even though they're not designed for mental health, people are using them for having mental health conversations. There's a vulnerability risk, privacy exposure, bias and exclusion, definitely as a risk, and no clinical oversight, given that it's not designed to have mental health conversations or health conversations as well. Um, just one example of what a professional body has released as a checklist for what a product or a company needs to be very aware of when they're creating AI for mental health. There should be clinical leadership. There has to be compliance, for example, with HIPAA. If you're in UK, it has to be the GDPR. It has to be the DTAC. It should easily integrate with workflows so that there is transparency for both the clinicians and the patient of what's happening and how the app is being used. Clinical evidence is non-negotiable. There could be security and certifications. For example, we have the ISO 27701, which and ISO 27701, which is for information security and privacy management. Informed consent is again a non-negotiable, and this is exactly what Orca really appreciated about us and gave us a rating on being the safest and most private app. Um, Again, personal data collection, how is the data handling being happening? And we will discuss all of these points in the webinar, so I won't spend much time on this slide. Some other pointers that one really needs to keep in mind while designing AI and the ethical boundaries we need to keep in mind are human oversight. There has to be privacy by design. It is a non-negotiable. Ethical guardrails, whatever exists today in your geography, or the best practices that exist around the world. Inclusivity and fairness, safe use of generative AI, and continuous assurance. So it is something that I've been saying in most of my conversations are that once you build a product, you really can't shelf it and also leave it for the consumers to use. If it is in use, it has to be constantly tested, constantly human moderated. There have to be feedback loops, real time but controlled responses as well. I'll take a pause here and request our next speaker to come in.
Right, I will go back. So thanks, Smriti. I would now like to introduce Professor Nicole Martinez to join us. Nicole earned her JD from Harvard Law School and a doctorate in social sciences from the University of Chicago, where she focused on comparative development and medical anthropology. Her research explores how new technologies impact vulnerable populations, including cross-cultural approaches to mental health services in the Latin community and the use of neuroscience in criminal cases. More recently, she has focused on the ethics of AI and digital health technologies, including digital phenotyping and computer vision for both medical and behavioral applications. She has served as principal investigator on multiple projects, examining ethical, policy, and regulatory issues in machine learning and digital health, including privacy, data, governance, bias, oversight, and equitable access. Her NIMH funded KO1 Career Development Grant investigates the ethics of machine learning and digital mental health technology, with recent work addressing bias, inclusion, and the social implications of privacy and data protections for marginalized groups. Thank you so much for joining us. Over to you. And sorry if you had to hear that all again.
Thank you so much. Thank you for the introduction. I really appreciate having this chance to have this conversation today. As Fiona so kindly gave an overview of, I am a professor at Stanford. The focus of my work is on ethics of mental health, particularly digital mental health and mental health AI. And with Gen AI, we've really seen a shift in terms of this ethical territory, where initially, many of the AI applications, while they were supportive, they also tended to be more in the area of prediction, like digital phenotyping, bringing together information and applying, algorithms to it in order to try and predict if someone has an impending episode of depression or psychosis, trying to predict things like what medication might support them. And while there had, of course, long been conversation about the possibility of AI having a more central role in providing treatment and even providing therapy, it was Gen I that really thrust us much more quickly into that area. And so, oops, here, let's see, move forward. I'm just going to give a quick moment to mention some of the ethical issues, since that's what we're here for, is to have the broader conversation. But accountability, oversight, and safety have been really large issues with AI generally, because existing ways in many countries, and certainly in the US, the existing ways of ensuring safety, making sure that there was accountability for any problems with medical devices or medical software, really has had to evolve quickly and is still, needing to evolve in order to address AI. There's also this issue of consumer facing versus medical paradigms. So in health data, in the US and many countries, there have already been established ways of protecting health information. But with AI programs, you have much more data and many more questions about, whether it can be protected within, whether it's an app or within the various systems that are using AI. And this is particularly an issue when it comes to consumer-facing mental health AI. And I should note, Dr. Joshi gave a lovely overview of the frameworks and the kinds of attention given to issues like privacy, issues of we say bias and fairness. I often like to pose that as, is it going to work? Who does it work for effectively? And those are things that within clinical development of mental health AI, there are mechanisms, still evolving, but there are mechanisms for addressing that. But outside, in terms again of consumer-facing devices, there are a lot more question marks about how that might be done safely, and so that makes for definitely a very rich conversation. Informed consent, not just for data, and whether how your data might be collected, which often can be beyond just simply what most people are aware of, but also informed consent for that acknowledges the many ways that someone's data can be used downstream for a number of different uses, whether it's criminal justice, whether it's education, outside of even mental health, and hand in hand, since informed consent doesn't necessarily apply to a number of these, uses, is transparency. How can you get the information, whether it's from companies or otherwise, that will be necessary in order to understand both the safety of these kinds of devices, as well as transparency, as well as how they may impact people downstream. That goes hand in hand with privacy and data protection, and again, bias and fairness. I started out in this area. I started out in law, and I spent time as a criminal defense attorney, as well as in legal aid. So for people who can't afford legal services in the U.S. And one thing that really struck me was the number of people using the legal system, whether they were caught in the criminal justice system or caught in cycles of, not being able to keep their housing or otherwise, but the high number of people who had mental health problems side by side with their other social problems. And that is what really first interested me in this area, was in terms of both social support, treatment support, what would be necessary, what would help in this area. And certainly mental health AI provides a number of options for improving service, improving access. Again, as Dr. Joshi was talking about, there can be a number of different models that help with those gaps. But at the same time, there's these questions that with the way that these devices are developed, the way that they're deployed in context, who are they going to work for? Who's going to have access to them? And then also, I've been seeing people introducing themselves in the chat, and really just, lovely seeing the therapeutic experience and expertise we have in our audience from across the world. And these are, of course, other questions that when you have a mental health AI, especially Gen AI, which is being pushed into a more central role in some cases in terms of care, can you even say that there's a therapeutic alliance? Might you need to protect people from ways that getting care from an AI or alongside an AI may be different? So I laid all of these issues out. I very much welcome our conversation going forward. Thank you.
Thank you so much, Nicole. Can you hear me?
Yeah.
Okay, brilliant. Um, Thank you. I just want to invite Smriti to join the conversation as well. And before we jump into this discussion, a quick reminder to our audience, please post your questions in the Q&A box, and I'll do my best to bring them into the conversation. I think before we get started, it would be great to hear a little bit more from Smriti in the context of Wiser, what you did. You rattled through that slide on data in the view that we would have that discussion, but I think it would be great to sort of understand from your perspective what steps you've taken at Wiser.
Sorry, I was on mute. I think data is valuable. A lot of people say data is money, and it's been a hard decision that we've taken on many aspects when it came to what kind of data we wanted to gather, what kind of data we wanted to utilize, what kind of, and how would we seek consent, and what is it that we would tell our clients or our users or our patients so that they would trust us to be able to share that data with us. So I think those are all key things to keep in mind. Like Dr. Nicole was also saying, that it's the end user who's actually going to uh, be benefited, which is the intent, but also helping with the product, the service being more refined because the feedback matters. A lot of data that is used for research. So everything that they share with us is precious and very, very, very sanct in nature. So I think what we decided to do was that right from the beginning, we decided that we would never, and most of the regulations, specifically GDPR in the EU, the guidelines say that we do not have to store data on our servers, personally identifiable data. So right from day one, that became the thumb rule that we would not capture any PII or ePHI on our servers. And even when individuals would share it accidentally because they're talking about their emotions, their feelings, their situations, it's possible that inadvertently that they do put in some data in there. And we kind of worked really hard to create models that would help identify that this is a PI, this is an ePHI, and redact it from the systems. So none of that information is saved in our systems at all. The user is the owner of the data, and that is something that we have ensured, because the minute they click reset my data in the phone settings, and this is something that they're made aware of when they're onboarding, and also in the terms and conditions very transparently, if they click reset my data, everything goes away, nothing stays with us. So we've ensured that we followed these best practices very carefully. And I think what really helped is the initial partnerships that we had with large public health bodies like the NHS, or say an Aetna or an Allianz or an Accenture, who've been our partners, and they all wanted us to showcase to them how we would protect the user data of their employees, of the patients who are coming in the systems. And all those due diligences exposed us to different guidelines and different regulations that existed in various parts of the world. So something that is a learning for now and for anyone who is getting into the space or is working as a leader in the space is to remember that even though today we may not have the perfect set of guidelines for every geography or for every use case, there do exist just very first principle basic guidelines that we have been applying in our medical settings, that we have been applying for research where real patient data is taken into account, the way we are seeking informed consent, letting them know very transparently how we are going to use this data. Will it be shared with the third parties? Will it be sold to third parties? Uh, right? So everything needs to be shared transparently. I know it's a hard call because we will lose users, we will lose clients and patients, and the rates may just drop when they see it, or it may never take off. But I think these are some hard calls we have taken in our journey to ensure that the user data is considered precious and as sanct as it is meant to be.
Thanks. I think when I hear about the steps and the measures you've taken at Wiser, I think it really exposes the potential gaps of knowledge when people are engaging with the likes of ChatGPT or equivalents. You know, we often use ChatGPT as the reference, but it's not the only one. And I guess my question to you, Nicole, would be, in that context, what steps do we need to take to protect data and to make people aware of what best practice looks like? Because, you know, we hear stories all the time. We were reflecting yesterday as part of this panel prep. Quite often, people will respond to data when they see something coming through their Instagram or their WhatsApp, or these slightly outraged, you know, things around data being taken. But actually, every time that we use it, we are kind of willingly use like sharing our data and not necessarily taking those steps. And I think in the guidelines that Wiser have put in place, that's great. But obviously, in terms of Gen I and its reach, hundreds of millions of people sharing their data, what are the steps we can take to start making people really aware of what they're actually sharing?
I think some of that has been taking place over the last couple of years. That there have been some rather high profile uh, incidents where it turns out that even services that put themselves forward as services that are meant to help with mental health, but that are still working with chatbots or selling data. So, for example, there was a suicide hotline in the U.S. A year or so ago that it came out that it was actually selling data to third-party users. And I would also say that, with what Dr. Joshi was outlining as best practices, in some ways it's the kind of inverse reflection of the kinds of things then that I would say people need to be aware of, to be concerned about. One thing is that, of course, there's just simply, taking, what happens that they're taking people's data, they may be selling it elsewhere. And that's where regulation like the GDPR in Europe come in very important, that you need to get people's consent in the processing of their data. That includes outside of health systems, having that consent for processing data. Things that people are often less aware of. And in my research, when I talked with clinicians, they know to be concerned about the content of what might be in their sessions, but they may not be as aware that most apps have been found to collect a range of information from their users that in itself can be sold downstream. And so having both awareness that that is possible, but also looking for ones that have better practices, like what Dr. Joshi was describing. On top of the data itself, there's inferences that can be drawn from that data, profiles that can be drawn from that data. So, for example, even if someone isn't personally identified by the data, there are ways that profiles that can follow them that show this is an anxious person. This is a person who is likely to have an episode of depression, and it can make them vulnerable, both in terms of which systems use that. Like if it, in some cases, educational systems can use that to profile prospective applicants, but also in terms of marketing. There are a number of incidents where someone might be identified through their profile for an incident of mania, and then purposely targeted for high price ticket items during that time because they are particularly vulnerable to that. And so that's where I'm saying that, all of these different uses of data, having that education around it is very important. And the last thing I would say, particularly in the area of Gen I, is also the way your data may be used to train that system further. Having the awareness of and this happens even with when medical systems make deals with different Gen AI systems, that then a lot of patient information might be used to train that system. There are still sometimes concerns that come out later on where that patient data pops up down the line, revealed because there weren't necessarily proper safeguards. But it's also, I think, more awareness that that value of patients' data can be very important, and people may not even be aware that their own sessions, their own data is being used to further build these systems that people are profiting off of.
Thanks, Nicole. I just want to revisit that point about profiles to you both, actually, in terms of, I think one of the concerns, particularly in our community, is this idea around some of the data that we're collecting propelling bias, and not necessarily reflecting the diversity of the communities that we serve. So, how can we spot and reduce biases in AI that may affect underrepresented groups, particularly where that volume of usage is driving that profile creation? What steps can we take to mitigate for the bias that probably inevitably comes up as a result of that? Should I start with you, Nicole, and then if we come to Smriti?
Okay. So I think some of those steps are really in the hands of the companies and developers. So From the clinical point of view, some of it can be is finding the spaces to bring awareness to that, to show that this is something that's a concern. And also paying attention to, is there information about, where this data came from, who it was trained on, who it seems to be more effective with. But I should say a lot of times that data isn't available. So that's where I'm saying that there is really more weight on companies, developers to make that information more transparent, where their training data may have come from, what kind of evaluations, different sites that has been evaluated in, as well as attention to when you're talking about Gen I think that one thing also to be aware of more is things that are in the design itself, like what kind of language is used. What are the ways that even the language that's used can be accessible or end up excluding certain populations. And especially, of course, now there's been more attention how that might be according to, sort of race, what language. Many of these models have a lot of English speaking data, not as much work on non-English speaking, or on English as a second language. But also, in terms of people who are neurotypical, that a lot of that data, again, it comes from people who are neurotypical rather than neurodivergent, and so may really have issues in terms of how it connects with people who are not neurotypical. But I also know Dr. Joshi, has experience with in terms of more responsible practices when it comes to how a company can address these things.
Over to you, Smriti.
Okay, thank you. And I think those were really golden words by Dr. Nicole, I think, because uh, as a clinician who has been working with this organization, I have learned everything by doing. The experience has really brought in more awareness than would have ever happened if I would have been on the other side, maybe a clinician who was recommending or just using an application. But because I have been a part of an org that has served millions of people, and we have millions of voices, millions of people who are constantly providing feedback. Like I shared, that it was a conscious effort to have as varied user panels and as varied clinician representation from different geographies in our board to ensure that at least the language that is being used is appropriate, is as inclusive as possible. I would say no data. If we are sure that this is the exact population or cohort we want to work with, the most basic first principle thinking is co-design. So in some of our work in India, when we wanted to bring all our knowledge and experience and the efficacy of our models uh, and start employing them with the population here in India with one specific language, Hindi, or another specific language, Marathi, because each of these languages, each of any of the languages across the world have very different terms, or maybe no terms, just expressions for how they experience various feelings or emotions. And when we wanted to work with specific cohorts and communities, and we knew that this would be deployed only with them, the process began with co-design. It began with going and doing think aloud sessions, or just gathering narratives around how they have been coping, what they have been doing, what is the language they use. So it was, and then building conversations that the bot would be having with them, or the kind of tools that would be given. A mindfulness tool maybe not very well accepted by a young girl who is in a rural area in India, because they have a lot of calm and peace around them. They are used to pauses in their lives. They don't have as much to get constantly stimulated with. So something that would be more active, something that would help them socialize more, learn some other skills would be more helpful. So just that learning these from our users and then bringing that knowledge back into the system is what has helped reduce bias for specific cohorts and communities. But also, say, for example, the global app, which is just out there, right? I think something that we did was to ensure that the language we use, the English that is being used, is not too complex. It was written by a non-native English speaker like me. A lot of those conversations inside the trees and the algorithms, the language in it were by uh, non-native English speakers, but also evaluated and went through rounds of approvals from different people, user groups who would be using the app. So representation is really important. Who I think, like Dr. Nicole said, who would be using these? Would clinicians be using these? Would people with mental health conditions be using these? Are we just seeing that anybody across the world would be using it? And eventually, as we see, and also having questions around helpfulness, also having questions around, did you feel heard? Did you feel understood? Kind of questions after conversation, and thumbs up on it or thumbs down on it helped us see where we were hearing or understanding individuals better, and then to work on it. So, like I said, that assurance is really important, that representation assurance, that it is being tested and retested, and then there are aptness testing happening for the models and aptness testing happening for the responses that the bot is giving, the AI is giving, all of that, regardless of the fact whether the bot is meant for mental health or not. Maybe even if it's an open AI, if I'm asking, if the conversation is happening on a certain topic, will it going to diverge because I said something different from the topic? Will it understand that this is going down a certain pathway, it should not be going down a certain pathway, and then kind of revert and bring it back to the original conversation, understanding where there are red flags, where there are safety risks involved? I think all of that will only come when there is representation, when there are people who are reviewing and testing, um, and then really working hard on putting all that knowledge back into the
Mhm.
uh,
I think
AI
as you're
models. Yeah.
talking, I think, what you've described in terms of the creation of a digital mental health solution. Obviously, you talked about Orca, and we'll come on to assurance shortly. But I think that this is there's two tracks that I've got going on in my mind. On the one hand, you describe, yes, the process for a digital mental health technology solution. But on the other hand, we have a lot of people engaging in more kind of well-being style scenarios that I think does continue to open up some risks around profiling and data. But I want to turn to the audience very briefly because we had some questions that I think pertains to this part of our discussion. The first one is from Taryn. When mental health models draw on client stories or lived experience to create resources, training, or IP, how should we consider cultural or collective ownership of those stories, especially in Indigenous or community-based contexts where knowledge is not individually owned?
I
Yeah,
think that's a great question. Sorry, you go, Dr.
go ahead. No,
Joshi.
no, Dr. Nicole, please go ahead.
Um, I, I think that's a wonderful question. I think that's something that people that in this area, I think there's a lot of discussion, a lot of question around that. There's a really interesting example actually coming out of New Zealand of the when of uh, large language models, but basically larger companies kind of using the work that Maori had done in New Zealand to reclaim language, and larger companies coming in and trying to sort of take that language to train their own models. And there was pushback on that, where there were actual, sort of local knowledge, local um, computer scientists, data scientists who did their own project to use their language more on the local level and develop language models from that. And I think that that really is an interesting illustration of that. Unfortunately, with a lot of Gen Gen AI, the sort of scale of it is that it attracts these sort of large big data companies to come in, but that there are at the same time a lot of opportunities that if there is infrastructure or support given for more local communities to be able to sort of build their data, to have more projects where they are able to have more ownership, more say over their own data. And so and as I was saying earlier, there are also questions even at the broader level of patients and their ownership of data that's being used to build these very profitable systems. This is something that, you can look at models of how this may have been done in genomics, but it is something that's still evolving, and I think a very important question and area.
Thank you. And Smriti, did you have anything you wanted to add?
Yeah, I think Nicole made the point pretty well, but I think it also reflects in the care principles, which is collective benefit, authority to control, responsibility, and ethics for indigenous data governance. And these principles are still being worked on. I think they exist in terms of how it's being used for research, and I think maybe Nicole would be able to comment on it better. I've been reading a lot of it ever since we started our work in India and working with local communities from tribal areas, from villages, from rural areas here. And I do feel the benefit must flow back. The people who have shared this data should feel represented in the data, in the way it's being utilized. Say, for example, a young girl who has contributed to the app or a digital product that we've created in a specific language, they should be able to see that contribution there. It should not be turned into just a simple data point. They should feel represented that, oh yeah, I shared with them and I can see it right here. Because it become, like you said, it's collect like in the question, and I loved the question when I read it, and I had the urge to just type in a random response right in there to Taryn. So thanks a lot for this question. I think the benefit must flow back. There should be some sort of a collective understanding with also stakeholders in the community to see how that data will be utilized, uh, uh, and also probably with times as cultures and languages also evolve, changes that need to be made. So I think that representation point that I also made for mitigating bias earlier is very strong. It should exist, and this work should happen in. Uh, it should not pause. It's a work that should happen in there's a flow. So once it's in and people are using it, and then if you realize that there are changes happening, say for example, a community is slowly getting more advanced, there's more work happening in those particular areas, the language is changing, maybe some of the things that earlier existed and that is being reflected in the data set should then be worked on and made more appropriate and relevant to the community at that particular point in time. I think time is also of essence.
Thank you. Yeah, it was and is a brilliant question. While before I turn back to bias, I'm just going to pick up some questions in the Q&A box around data specifically. And we have Nina. Hi, Nina. What do you recommend in terms of understanding the connection or distinction between data collected within the e-mental health apps, companies, developers, and the data collected as part of a patient's electronic health record? How do you deal with the sensitivities of the two systems, the system that collects EHR records versus the system that collects mental health data? And there is a follow-on question to that. Are there any examples of the two talking to each other? I think Smriti, as a product developer, I think you're probably well placed in terms of your experience in health systems to answer that.
Um, I think I would want to read that question if it's possible. It was a little long when you narrated it. Where I'll
It's
just
in
try
the
and answer from
Q&A.
what I
Yeah.
yeah, it's in the Q&A. I'll try and answer from what I remember from the long narration of the question. So, in our work with the NHS or with the MOHD, where there is a patient talking to the app, and then there is a record that is in the EHR systems. Um, our data flows in any relevant data, say around clinical risks that come up in the conversations with the bot, or for example, with talking therapies, where they also use our clinician platform where their therapists are using the Clinish platform, which is owned by Visa, to get in touch with their patients if there is a need or if there's an escalation. So what happens is that data from Visa is shared with the patients only with their clinicians, only with consent from the patients. So the entire conversation or chats that they are having with the bot is not shared with the clinician. But if there are any screenings, if there are any red flags, if there is a SOS alert that is triggered in our systems because they detected the user mentioning something on the lines of, say, suicidal ideations or self-harm risks, then the clinician is informed and the clinician can utilize that data point to quickly check in with the individual and assist them. But the data does not flow back from the EHR into our systems because, like I said, we want to be sure that we are safe and we are following all the regulations and compliances and the DCB, the DTAC, all of that, the GDPR say that we do not have to store any PI or ePH in our systems. So the data flow is only one-sided, and that also happens only with consent of the patient. What is it that they would want to really share with the clinician? The non-negotiable part is, of course, the uh, self-harm and the suicidal ideations or any red flags on the screenings that are inbuilt into the systems.
Thanks. Thanks. I think it is this question, isn't it? How services like digital mental health solutions continue to evolve with the data they're collecting in terms of what, from a learning perspective, but equally how much that actually informs what healthcare providers and systems. I think it's a really interesting question. However, in the interest of time, I wanted to pick up a couple of questions in terms of we talked about this yesterday. Education around digital literacy is really important. And I think it plays into this question about how important we think it is for users and clinicians to understand AI decisions, to understand data that's being collected. The question from Lynn is, do you think data sovereignty by design is a universal approach to address the issues brought up today? Nicole?
Um, I think that I'm thinking more along the lines of sort of data governance situations. Data sovereignty, can be among communities, and that certainly is an approach that has worked in some areas in order to help support. So, for example, there's a number of examples with genomics and indigenous communities of using data sovereignty principles in order to support having benefit from that work for the particular community in which it's coming from. I would say, and that certainly, can be a very useful approach. But there's also, in terms of data governance, this often tends to take place in terms of thinking at more local levels, like whether it's in a health system, a particular system that's implementing mental health AI. And one thing that has been really, I think, coming up as a trend, and it goes hand in hand with what Dr. Joshi was saying about, participatory design, is having, again, stakeholders involved in discussing, what are priorities for data governance? What are the ways that, what is the transparency that they want to see? What are the priorities in terms of benefits coming from that information, as well as what risks they want to be prioritized. Many times with privacy, there's trade-offs. You can learn from the data in ways that can benefit from communities, but at the same time, there can be risks. And so having more participation of communities, of local stakeholders, has been something that has gotten more movement in terms of these kinds of mental health AI systems, as well as medical AI systems in general, of the need to bring people in as part of the decision making of how to set up structures for using and protecting data.
Thank you. The next question is from Andy Greenshaw, who very kindly hosted the last AI session that we had. Hi, Andy. His question is, and again, this is a longer narrative, so if you want to just both have a quick look at the Q&A box, but playing with Anil Taplial's global concept, thinking about equity, diversity, and inclusion, how can we reconcile local needs with overall development strategies? Gen AI can handle diversity, but questions arise about what fits. Locally and globally, this is an issue. Consider ethics and cultural diversity in a city contrasted with internationally. Nicole, you're nodding. I just wanted to know if you've had any thoughts on that.
I actually was thinking about this before when we were talking about bias and fairness, and when Dr. Joshi was giving these lovely examples of working with local communities, that I think that the marketing of AI and why there's a lot of investment in it is this idea that it's going to be this objective tool that can just be plugged in anywhere. When the reality of it is, and many data scientists, computer scientists that I talk to affirm this, is that it's very much something that always needs to be adjusted for local context, that always needs to take into account not just the data that was used to train it and whether that matches the target population, although that certainly is a big part of it, but also how is it going to be used in local context? Who's going to be using it? There was a recent study by MIT that found that like 95% of AI in industry does not yield any benefit. And a big reason for that is because they have not taken into account things like how it fits into workflow, how it fits into what the actual specific problem it's being used for actually is, and how to adjust it for that. And so I'm bringing all of that up in saying that I think that the reality of it is that um, AI always has needed to be adjusted for local contexts and local communities. And that the more that it moves beyond the marketing of it to pay attention to that and have support structures in place so that it's not seen as a one size fits all tool, but instead something that will need to be adjusted, whether it's through participatory strategies, whether it's through co-governance strategies, whether it's through evaluation procedures that actually take into account the needs of different stakeholders. But that is something that I think for AI to really yield benefit, there needs to be more movement towards that. And you do get more recognition of that within both clinical and computer science communities. We also have practices that can help support that. And I think it's more at the sort of funding or regulatory side that hopefully we'll see more movement in that area.
Which is perfect. I'm conscious of time. We've got 5 minutes left, but I just want to touch upon this element of assurance. Obviously, Smriti, we had this good discussion yesterday about the extent you talk about co-production. We've talked about kind of, how we continue to evolve our approach from a regulatory perspective. But I would question how quickly the regulatory is moving to support some of the answers to these questions. And in the context of, certainly we talked specifically about the UK, but in terms of how it's continually looking for evidence of co-production. And I just wondered if you could share your reflections on that, based on your experiences from assessment frameworks, not just in the UK, but globally. And if there are any examples of countries that you think are getting it right in terms of really understanding what it is that they're engaging with when they look at an AI-driven mental health tool.
Uh, I think I began the conversation today with and it's been something that Dr. Anil and eMHIC and I have discussed often, which is these guardrails, these guidelines are very quickly evolving. Something that was relevant a couple of years ago isn't relevant today as much for some particular things, but not for everything. There are some basic principles that will always be true, which will help us ensure that uh, if we are building an e-mental health platform or an AI for mental health or an AI for health, we'll always be on the on uh, a pathway which is ethically and legally safe for all stakeholders involved, whether it is the creators, whether it's the team that is working on it, whether it's the clinicians who are making the recommendations, or and also for the users who are the beneficiaries of such activities. And I think uh, there are some countries which have a lot of these guidelines and best practices already in place. For example, in the US, I think because telemental health started there very early, much earlier than it happened in anywhere else in the world. They kind of understood a lot of things around with the research and with the knowledge that they gained with building those platforms, moving from telemental health to digital health to AI. It seems that the knowledge base exists, but I also feel that what we have spoken about with Dr. Nicole and you, Fiona, is that there's also a knowledge gap while the knowledge exists. So I think the knowledge is still not uh, it doesn't sit with people who are building these products. It still sits in labs, it still sits in um, uh, uh, probably public health systems, but a large majority of these apps are not being created by people just in the labs or by those in the public health systems, because you need tech partnerships, and tech companies have more knowledge on how AI works, or now in the tech pieces, the coding, the deployment, the product testing, the product life cycle. So I think the knowledge gaps can be filled when all these collaborators come together and there's a lot of knowledge sharing that happens. For example, as a clinician, I don't know what DTAC means, frankly. I don't know how to implement that if today I decide to start a company and build my own AI. I do need somebody who understands DTAC. I am not a lawyer, I'm not a legal person. I don't know how to interpret certain regulations or compliances that may exist for a certain geography. So I think cross collaboration is really important to fill the knowledge gaps, that knowledge sharing, the literacy piece that we were talking about. And there has to be a set of living guidelines and documentation that keeps evolving with time. But again, never to forget the basic first principles that govern healthcare systems, whether it's the principle of malfeasance or non-malfeasance or beneficence or privacy, etc. All of those things.
Thank you so much. And what a wonderful way to end our webinar. I think particularly apt for an eMHIC audience, the themes of collaboration and partnership. So as we wrap up, a huge thank you to our amazing panelists, Rusi and Nicole, and to our wonderful audience, as always, for being so engaged and asking some really great questions. I think what this has highlighted yet again is that there is still so much to talk about. We've talked a lot about data and bias and those connections with health systems, but there is still this whole conversation to be had about how the rest of the population who may not be engaged with health services is engaging with the likes of Gen AI and what that means for our services, both in the good and the bad, particularly in the context of prevalence. So I want to say a really, really, really big thank you. I am sure this will not be our last webinar on AI, but before we go, a quick reminder that the eMHIC 2025 Congress is just 2 weeks away. It feels like the last one was only yesterday. It's taking place on the 19th to the 21st of November at the Western Harbour Castle in Toronto, Canada, and online. This is an amazing opportunity to connect with leaders from over 40 countries, explore cutting-edge digital mental health solutions, and help shape global frameworks for mental health equity. For those who haven't registered yet, we'll share the registration link in the chat. This is a landmark global event, and we highly recommend it to anyone interested in the future of mental health care. Thank you again. I can see that there's an ongoing conversation in the webinar chat, which is great, but unfortunately we do have to end it here. But we hope you have a wonderful rest of your day or evening, whatever day it is, wherever you are in the world. Thank you very much.
Thank you all. Thanks for having us, eMHIC and team.
Thank you very much.